Hello, I'm Dr. González from Hospital Clinic of Barcelona. I will talk about transanal total mesorectal excision for rectal cancer, pattern of local recurrence in a tertiary referral center. First of all, I have nothing to disclose. So as you all know, transanal total mesorectal excision was designed almost 10 years ago. Since then a lot of publications have pointed out some benefits of this approach in the treatment for rectal neoplasia. Several short-term analyses had already been done with good results, but long-term analyses are lacking. Over 200 articles have been presented, but the first important or heavy article was the International TA Team Registry with more than 70 centers talking about the safety of TA-TME. From then on, the meta-analysis compared TA-TME with previous surgical approaches shows some advantages in histopathological results, in lower permanent stomach rate, and lower conversion. So the theoretical benefits are improved surgical resection, improved midterm oncological results, and lower rate of permanent stoma. But from then, a study of the British Journal Surgery appeared that says that 9.5% of their patients with TA-TME present an unexpected local early recurrence pattern with rapid multifocal and pelvic growth in cavity and side walls. This was confirmed by the national audit, so they stopped performing TA-TME. So the aim of our study was to analyze the rate, pattern, and time to local relapse and to determine the consequences of this pattern for the tailored therapy. So we analyzed the results of our Hospital Clinic in Barcelona, and adenocarcinoma up to 12 centimeters from the anal verge from 2011 to 2018, stage 2-3 rectal cancer with one team or two team rectal approach. And the exclusion criteria was emergency procedures, previous local excision, pelvic exenteration, and pelvic malignancy the last 5 years. So we had a cohort of 365 patients that we have 116 excluded with a complete analysis of 205. 15 of them were lost in the follow-up and 12 patients died. Some features, characteristics: the mean age was 75 years old with a mean distance of the anal verge of the tumor of 7.2 centimeters. The 50% of the patients has an anterior tumor, and almost 40% of patients have EM/I positive in the resonance. So what about the histopathological analysis? The most important, what we present here, is that the CRM involvement was already 12%, including T4 tumors, and that the TME was complete in the 95% of the cases. It's the oncological results. Our cohort has a follow-up median of 30.9 with a disease-free survival at 3 years of 75% and an overall survival at 3 years of 88%. The local recurrence was appeared in 7 patients. That it's at 3.4% with a time to local relapse of 31 months. So here you have some of the local recurrence data in our patients. We want to point out that 4 of the 7 patients have risk factors of local recurrence, such as T4 tumors, incomplete mesorectal excision, CRM positive or distal resection margin positive, but neither of them has local recurrence patterns such as described by the BGS, so we don't have multifocal recurrence. Here we can see the Kaplan-Meier plot for our local recurrence with an average follow-up of 30.9 months, the local recurrence of 3.4, and we see a relapse later than expected. As we see, the censuses were well distributed in the center of the curve, although the number of patients at risk from 5 years of age decrease. So after that, we cannot analyze the result, and we should do a greater follow-up to say something about this month. Here you have also the disease-free survival and overall survival curve with the results commented. Overall survival over 88% at 3 years, and disease-free survival over 75%. And we perform an univariate analysis of the risk factors that are supposed to be increasing the risk of local recurrence. All of these factors showed an increased risk with significance, but we would not be able to perform a multivariable analysis because we had lower number of events, only 7 local recurrence. If we compare the results of the previous studies that talk about the same topic, we see that 3 of these 6 studies present multifocal recurrence, and most of them present low local recurrence, except of Larsen and Van Ostendorp. But the results of TATME could not be so bad as presented in the BGS. So after that, we have some questions. It's necessary analysis of the TATME. Yes, it's necessary. Someone said that centers of excellence should perform TATME. So for analysts to know this, we have to wait for the results of Colorectal study, that it's a multi-center randomized clinical trial comparing TATME versus laparoscopic TATME. So as some papers on the British Journal Surgery says in this paper, we know that there is a learning curve, right? It's possible that the learning curve for TATME is steep. So we have to do something to approach these 2 curves. For example, Dr. Hompens recommends in one of these papers to perform a dual purse string in order to avoid cell spillage into the abdominal cavity due to the high insufficient pressure. So some of the conclusions, it's like this study, our results show favorable midterm oncological results of TATME for patients with locally advanced and mid-low rectal cancer, that an unexpected early type of regional recurrence was not observed, and it's necessary to have the results of Color3 trial to analyze finally the TATME, and that international networks are interesting and useful for studying all the new procedures that are emerging. Thank you for your attention, and at least I hope that everybody is safe in your house during this COVID-19 crisis.